A lot of people look at altered mental status as a problem or a disease, and it's often actually used as a chief complaint or a common presentation, but altered mental status, or AMS, is not a disease in and of itself, but actually a indication of some underlying problem that's affecting brain function. Now, the problem with this is that these altered mental status patients are vulnerable. They can't protect themselves from the environment appropriately. They may have lost their gag reflexes, their cough reflexes. They may not have impaired muscle tone, so that could be an airway obstruction. Respiratory rate may be depressed. And if they have involvement of that hypothalamus or brainstem, they could lose the ability to regulate their body temperature, blood pressure, heart rate, respirations, important things. And a lot of the things that actually can cause altered mental status also can put them at an increased risk for seizures. So altered mental status is not a good thing here. So what we're doing for management of this altered mental status, we are managing that airway, the breathing, and circulation, and we're looking for potentially correctable underlying causes. A patient who's conscious can protect their airway and their ventilations a lot better than we can for them. Now, important thing to keep in mind here, typically if we need to manage that airway, we're going to look at like NPA, OPA, that kind of stuff. If you think or suspect reasonably that their altered mental status may be due to like a hypoglycemia, narcotic overdose, or something that you can fairly easily correct, you may want to defer insertion of an OPA or oropharyngeal airway, an advanced airway, until you've treated the patient for those conditions. Otherwise, if you don't, then you kind of wake them up essentially from a correctable cause with some device in the airway. They could panic, they could vomit, could lead to injury. But it is very important to note that if you do defer the use of an OPA, you still must manage or must continue to protect that airway and ventilations. So you may need to use manual maneuvers or like an NPA or something like that won't activate that gag reflex if and when they come around. Couple things to help you remember the potential causes of altered mental status, along with the AEIOU tips, but also this is called Move Stupid, which always just kind of makes you chuckle a little bit, but it gives you metabolic, oxygen, vascular, electrolyte, endocrine, seizures, tumors, uremia, psychiatric, infection, and drugs. So those are just some of the more common potential causes, things to include in your differential. Some of those we can check, some of them we can't. Also important to note that AMS could also include like your behavioral problems and things like that, but we're not going to refer to these behavioral problems. We're going to assume and operate under the assumption that it is a potentially underlying medical cause rather than a psychiatric, unless they are known to be under the care of a psychiatric facility or doctor. All right. Also, make sure that you look for your signs of trauma. Anything that could have, traumatically caused this underlying altered mental status here. And of course, you're seeing safety. Safety is paramount. All right. And if you have multiple patients, suspect some kind of toxin. As far as suicidal patients go, I'm not going to go too far in depth because that'll be covered more later in the mental health. But consider a patient who is suicidal to potentially also be homicidal, because they may try to take out anybody that stands in the way of them achieving their goals. Just a little tidbit to keep in mind there. So treatment here, consider your IVs as indicated or as needed. We're going to use cardiac monitor if applicable. We're going to use capnography if applicable. We're going to check a blood sugar. Every patient with altered mental status gets a blood sugar check at least once. Okay? Manage the ABCs, transport in a calm, quiet manner, and monitor. For our syncope, syncope is just a temporary loss of consciousness, okay, and that's going to be from inadequate brain perfusion. A lot of times you'll have some neurological symptoms that will kind of precede this loss of consciousness, and they'll often describe, a narrowing of their field of vision, like tunnel vision, loss of vision, ringing or roaring in their ears just before loss of consciousness. And these symptoms can also happen in a near syncope episode as well. In the near syncope, however, they become lightheaded and feel faint, but they don't lose consciousness. Right? Now, by definition, your syncope is transient, which means it comes and goes. If that patient is still unresponsive when you get there, it's not syncope, it's something else. Most cases of syncope are going to be fairly benign, but there are some very serious life-threatening causes that can cause syncope. It's also important to note that a patient can get some injuries if they fall during a syncopal episode. So any patient who has had syncope or a near syncopal episode needs to be thoroughly evaluated and encouraged to be transported to the hospital. Now, a lot of the times with your syncope, the underlying cause is going to be more cardiovascular related, not neurologic, but it's important that you still look at overall assessment. So some of your more common causes are going to be something that, there's a component that's not holding its own, if you will, that's needed for adequate blood pressure, in other words, perfusion to the brain. So blood volume, heart rate, or systemic vascular resistance, or vascular tone. Right? All three of these components have to be balanced to overcome the effect of gravity and maintain perfusion to the body, or to the brain. So if you have changes in this blood pressure, it can trigger this response by the sympathetic and parasympathetic divisions of the nervous system. When you have an increased response by the sympathetic nervous system, it's going to cause increased heart rate and vascular tone. Increased response by the parasympathetic, however, decreases heart rate and decreases vascular tone. A small abnormality in one of these components can be fairly easily compensated by some adjustments by the other two, but if you've got a more significant abnormality or in one or more of the components, it could impair the ability to compensate, and then you have a problem and it leads to poor perfusion, which leads to your syncopal episode. Okay? If you have a small loss of volume, increases in your heart rate and vasoconstriction can compensate that. But if you have a larger loss of volume, then, or if they can't compensate for some reason due to medications or whatever, then the cardiac output decreases, perfusion becomes inadequate, and they go unresponsive. Oftentimes, once that unresponsive patient goes recumbent or lays down flat, the effects of gravity are reduced, and then perfusion to the brain is restored, and they regain consciousness until they stand back up. There are some medications that can limit this increase in heart rate, some beta blockers, things like that, or vasoconstriction that can cause syncope even when blood volume is normal. All right, a lot of these medications are used to treat your hypertension and your cardiac dysrhythmias. So important to get that good history there to find out if this could have contributed to their syncopal episode. And a lot of times, if they have a syncopal episode, they've just started a new medication or they've increased the dose of the medication, and so it may be normally well tolerated, but if they get a little dehydrated or something, or if they've just started taking a medication, they could have some issues there while they kind of balance it out and their body gets used to it. A vasovagal reaction or response can also cause syncope. And so basically what happens is the parasympathetic nervous system is stimulated, and it temporarily overrides the sympathetic nervous system that allows for that heart rate increase in vasoconstriction. So this can occur in people who have a highly sensitive carotid sinus or in response to stimulus like the sight of blood or needles, heights, things like that. And with this, usually witnesses are going to report that they were pale, maybe shaking, or sweating before they collapsed. Another cause of some of your syncope is going to be your cardiac dysrhythmias, and it could be too fast, too slow, but whatever's happening is not producing enough output to maintain perfusion. A lot of times this dysrhythmia may be transient, and it may be gone by the time you reach the patient. But cerebral perfusion is the important thing here, so we probably want to leave them supine if that airway is under control.